Alright, hi guys, very good evening to all of you, and let's get started with our today's session of previous year MCQs. Yesterday I have discussed 2020 NEET PG MCQs, and today we shall be talking about 2019 NEET PG MCQs, 2019-20 NEET PG MCQs. And before I start the session today, please let me know if I'm clearly audible and visible to all of you guys. As I have also told you, for all the students, hi everyone, very nice to see you all. That every day at 6 p.m. I will be live on YouTube. My session at YouTube every day at 6 p.m. right? That will be discussing PYQ of NEET PG. Right? So yesterday I have discussed about 2020. Today I will be talking about some of the 2019. Okay. A very good evening, everyone. Please let me know if I am clearly audible and visible to all of you guys. If the audio and video both are absolutely fine, please give me a thumbs immediately. The code that I have also told you is Pharma10, very easy to remember. Okay, great. Alright, at the Unacademy app, usually at 4 p.m. I am coming live. I am sure some of you guys have already watched that session. This is at the Unacademy app. Okay. Yesterday we have discussed general pharma. Today I have discussed part 1 of the antimicrobial. Tomorrow again at 4 p.m. I will be discussing antimicrobials. Second part of the antimicrobial, then rest of the topics as has been scheduled, like central nervous system in 2 parts, cardiovascular system. So this is purely an MCQ series. Previous to this, I have done crash course as well for the FMGE students. If you're planning to join Focus FMGE batch, that is starting on 22nd of February, you can join it, right? So without making any further delay, let's get started. The very first question that we are having is, right, this is your 2019. Right, which of the following fluoroquinolone has maximum bioavailability? Right, so this you can consider as a general pharma question, or you can also consider as consider this as one of the antimicrobial question. Please start responding to this one, and then we can start discussing it already. Okay, so some of the students have already started giving the answers already. I can see here that the answer that is coming is A, that is levofloxacin. Very good, all of you guys. Now remember, among fluoroquinolones, we'll go very rapidly, very rapid MCQ discussion will be done, because all of you must have seen these MCQs already in several social media platforms. Fluoroquinolones, one of the DNA gyrase inhibitor, right? There are certain fluoroquinolones like levofloxacin or ofloxacin. They are having very high oral bioavailability. Because of this high oral bioavailability, remember, their IV and oral dose, right, are almost same. Right? In yesterday's session, general pharmacology, also I told this. Right? So correct answer that we are having is levofloxacin, as has as most of you guys have agreed here. Okay. Ciprofloxacin is considered the drug of choice in prophylaxis of the anthrax. Another MCQ that has been asked previously. Okay. Gatifloxacin that we are having, it is associated with your dysglycemia. G for glucose, right? Remember, associated with the dysglycemia. Because of this dysglycemia, it is actually withdrawn. Not marketed in our country. Topical route is available, but the systemic route is not available. Clear? So I hope this much information is enough, and we can quickly discuss the next questions. Correct answer that we are having, maximum oral bioavailability, is levofloxacin. Okay. Now, which of the following the examiner is asking the best approach in the treatment of the chronic SIADH? Which one do you think would be the best approach? Is it reducing the fluid intake? Is it tolvaptan, demeclocycline, fludrocortisone? Please start responding, all the students. Let us see how many of you can get this easily done. सब लोग try करिए, है ना? The best approach for the treatment of the chronic SIADH, syndrome of inappropriate ADH secretion. Okay, A, C, B. Okay, so some of you are in favor of C, some of you are in favor of A as well. Okay, always remember, guys, whenever we talk about the SIADH, there is a syndrome of inappropriate ADH secretion. Okay, then over the collecting duct, you are having the V2 receptor, right? Because of the excessive ADH that is coming, right? Excessive ADH that is being secreted from the brain. Right, all these ADH, they are going to cause more and more stimulation of this V2 receptor, and more aquaporin will be generated, that is going to cause the water reabsorption. that will be causing inside the body, the patient will be having dilutional hyponatremia. Dilutional hyponatremia. Because of the V2 stimulation by the ADH, there will be aquaporin generation, and they will be causing more and more water reabsorption, that is causing dilutional hyponatremia. And the urine that we are having, urine will be hyperosmolar. Urine concentration will be very high. So hyperosmolar, right? Osmolar urine. Hyperosmolar urine. Okay, remember this. Therefore, the best approach that we are having, you should give the blocker of the V2. And V2 receptor blocker that we are having are the Vaptans, right? That is your tolvaptan, and other one that we are having is the conivaptan. Tolvaptan and conivaptan, remember, right? All oral. So tolvaptan is available by the oral route. Conivaptan, coni IV, it's available by the parental route, IV route से. Conivaptan IV available है. Tolvaptan is available by the peroral route. Okay. So the best that we are having is the tolvaptan. Others you can also use, like for example demeclocycline associated with the diabetes insipidus. Therefore demeclocycline can also be used. Reducing the fluid intake is an additional step that you can take, but this is not the best approach. Just reducing the fluid, right? If you have to choose between tolvaptan and reducing, definitely tolvaptan is going to be more preferred. So it is not going to be be any A or C. The correct answer that we are having is B. Okay. Dr. Khan, good evening, and good evening everyone. So I hope all of you guys are satisfied here with this answer. The best approach in the treatment of SIADH is tolvaptan. This is also 2019-20 question. Next question that was asked in the same year was cilastatin is administered to prolong the action of meropenem, imipenem, both A and B, and none of the above. Let us see how many of you can get this easily done. Right? Cilastatin administered to prolong the action of meropenem, imipenem. So majority of you are in favor of B. Some of you are also in favor of C. Remember guys, the prototype drug for the carbapenem that we have is imipenem. Correct answer, I am telling you, imipenem. This is the prototype drug, or you can say the first ever carbapenem that has been approved. Remember, prototype carbapenem will be imipenem. The problem with them is that they are easily degraded, or you can say the breakdown of this drug, right? It will be done by enzyme that is released from the kidney by the name of your dehydropeptidase. So by the dehydropeptidase, since it is released from the kidney, you call it as a renal dehydropeptidase, right? Renal dehydropeptidase. Your agent cilastatin that we are having, it is simply going to inhibit this dehydropeptidase. Therefore, this cilastatin addition is required only with the imipenem. The second generation carbapenem that we are having, like meropenem, ferropenem, all the other one that we are having, meropenem, ferropenem, you do not need to add cilastatin or renal dehydropeptidase inhibitor. Simply giving that particular drug, they are inherently resistant to this particular enzyme or degradation, enzymatic degradation. So you will not be giving with the both, only with the imipenem. And remember, imipenem is the only one that is usually maximally associated with your reduction of the seizure threshold. Therefore, they are also maximally associated with the development of the seizure. Okay, the second generation are less associated to not associated at all. Okay. All right. Which of the following anti-glaucoma medication is unsafe in infant? Another question that has been asked. Let us see how many of you can get this. Anti-glaucoma medication which is unsafe in infants. Is it timolol? Is it latanoprost? Is it brimonidine? Is it dorzolamide? All of you please start answering. Okay. Dr. Krish is saying brimonidine, that is C. Brain suppression, that means CNS suppression you are telling, right? Yes, very good. So the one that is safer in infants, right? Sorry, unsafe in infant that we are having are the alpha 2 agonist. Infant, not only this, elderly also, they are unsafe in elderly as well because of their drowsiness as side effect, right? Alpha 2 agonist, that is your apraclonidine and brimonidine. Apraclonidine, Brimonidine, C is the correct answer that we are having. Okay? Dorzolamide that we have, it is the preferred anti-glaucoma drug in the pediatric population. Preferred anti-glaucoma drug that happens to be one of the carbonic anhydrase inhibitor. Okay? So Brimonidine, they are actually causing your CNS depression, right? CNS depression, and they can even cause your development of the apnea, right? Because of this particular reason, it is actually contraindicated in the elderly and infants. Okay, I hope this much information is enough. So we can discuss more question, less of the information about this question, but more number of question practice, because all this information we have discussed in our regular classes already. Okay. Drug of choice for invasive aspergillosis. Another question that was asked in 2019-20, drug of choice for invasive aspergillosis. Let us see how many of you can get this. Please start answering, guys. Which drug do you think is going to be considered as a drug of choice? Start answering it already. Is it caspofungin, posaconazole, voriconazole, liposomal amphotericin B? Not very difficult one, because we have discussed this already. Excellent, all of you. Any case of the aspergillosis, this is the drug of choice. But remember, boys and girls, posaconazole can also be used. Yes, posaconazole can also be used. Voriconazole, it is considered as a drug of choice that we have. Okay. Liposomal amphotericin B that we are having, it is a drug of choice in any serious fungal brain infection. Any serious fungal infection, including the neurological infection of the brain, fungal infection. Caspofungin, anidulafungin, micafungin, they are the fungal cell wall inhibitor, right? Cell wall inhibitor. They can also be used for the aspergillosis. They can also be used for the aspergillosis. They can also be used for the candidiasis. They can also be used for the febrile neutropenia. Febrile neutropenia, उसमें भी preferred agent है caspofungin. They can be used, but the drug of choice is voriconazole. Another question that you should know, voriconazole is the shortest T half-life. It has shortest T half-life, that is around 6 hours. Among the triazoles, it is having the shortest T half-life, around 6 hours. Okay? Moving on to the next question. Okay. So this is the one. Broadest spectrum is posaconazole. First azole that is effective against mucormycosis, and voriconazole shortest T half-life. Drug of choice in aspergillosis, isavuconazole longest T half-life, around 130 hours. Okay. Which of the following antihypertensive drug is avoided in a patient with a high serum uric acid level? Another question that was asked, and multiple students have marked this correct, right? 2019-2020 question है ये, ठीक है? Please go. Yeah, echinocandin is the name of the class, Dr. Abhishek. Excellent. Okay. Brimonidine खुद apnea कराता है ना डॉक्टर, तो definitely contraindicated in the apnea patient. Dr. Krish, है ना? Chitin, Abhishek, chitin is the component of the cell wall only. That is why I have told you simply the cell wall inhibitor. ठीक है? So which of the following is contraindicated? All. Excellent, all of you. है ना? So the one that is going to increase the uric acid level, that is none other than your thiazide diuretics. Okay, so hydrochlorothiazide, they can increase the uric acid level, and therefore they can increase exacerbation of the gout, increase the uric acid level. They can even cause dyslipidemia. They are even shown to cause the dyslipidemia, and can even increase, right, the glucose level, Therefore very carefully given in the diabetic, dyslipidemic, or the gout patient, right? Very carefully you should give this. Avoided in patient with the high serum uric acid. Okay, then you should remember a very important thing, that there is one such agent by the name of losartan, right? Losartan is one of the angiotensin receptor blocker that increases the uric acid excretion. Yes, losartan increases the uric acid excretion. Yes or no? Then you also should know that there is one more drug, fenofibrate, boys and girls, is one of the PPAR alpha agonist. That is one of the fibrate, peroxisome proliferator activated receptor alpha, that is going to cause more and more breakdown of the triglyceride. Okay, so fenofibrate, it is also having the property that can increase the uric acid excretion. It can even cause uric acid excretion. Therefore they will be preferred in the gout patient. They are going to be preferred in gout patient. Different drugs, different class of drug. Okay? Getting a point? But hydrochlorothiazide, they will not. Hydrochlorothiazide, they will be contraindicated. Remember this. Apart from this, one anti-tubercular drug that is contraindicated in gout patient, that will be a pyrazinamide. I tell you, pyar dard dega, pyrazinamide will be increasing the uric acid level as well, है ना. So pyrazinamide will also be causing hyperuricemia, therefore also contraindicated in gout patient. Yes. All right, great, excellent, all of you. Moving on to the next question. That is, okay. So I think this is the same information that is mentioned here, that is preferred in your nephrogenic diabetes insipidus. Okay. Which of the following drug act by inhibiting the transcription of DNA to RNA? Act by inhibiting the transcription of DNA to RNA, right? So that's an antibacterial drug. I hope all of you guys can easily get this. An antibacterial drug that is act by inhibiting the transcription of DNA to RNA. Okay. Very easy question, not very difficult. So it's I'll give you a hint. It's an anti-tubercular drug. Yes, the hint is it's an anti-tubercular drug. Excellent, all of you. Okay. So rifampicin is the one that is going to act by inhibiting your DNA dependent RNA polymerase inhibitor. Yes, very good, all of you. Okay, DNA dependent RNA polymerase inhibitor, rifampicin. Next that we are having, remember guys, ciprofloxacin is one of the DNA gyrase inhibitor, 5-fluorouracil one of the anti-cancer drug, furantoin one of the urinary antiseptic. Okay. A patient was recently started on flufenazine. Okay. Flufenazine. Few weeks later he developed tremor, rigidity, bradykinesia. Look at the symptom, tremor, rigidity, bradykinesia. Where do you see all this together? Okay, and excessive salivation as well. First line of management for this patient will be which of the following? I hope all of you guys can easily get this. This is not very difficult question. Not very difficult question. Okay, all of you please try. Dr. Vivekananda, China. Excellent, all of you. Excellent, all of you. B. Everyone is in favor of B. Now, what do you think? Flufenazine is which class of drug, guys? Flufenazine, perfenazine. What class of drug is flufenazine? This is one of the typical antipsychotic drug में आता है. Typical antipsychotics, है ना? Typical antipsychotics, and all these typical antipsychotics, what they are going to do? They are going to block the D2. Because of the excessive D2 blockade, what they can cause? They can cause development of the extrapyramidal symptom, right? Extrapyramidal symptom. Whenever D2 will be blocked, right? So there is a decreased amount of dopamine. Dopamine will be reduced compared to acetylcholine. Okay. Because of this imbalance that has been created, right? The patient will be having the symptoms like your tremor, rigidity, bradykinesia. Getting my point? Excessive salivation because of excessive acetylcholine as well. Okay. Now, in order to treat this, what you should do? You should bring this acetylcholine down so that they meet at the midpoint. Okay, or they can be balanced together. So you can give your patient one of the centrally acting anticholinergic, right? Very easy question, no? But just needed a little concept. Centrally acting anticholinergic drug. Okay? The drugs that we are having, drugs like your benzhexol, yes, benzhexol. Other drug that we are having is the benztropine, benzhexol, benztropine, biperidine, है ना? Procyclidine, trihexyphenidyl. So all of them, boys and girls, remember, are the centrally acting anticholinergic, and they can be used mainly in the secondary Parkinsonism disease. You also call it as a secondary Parkinson disease. So correct answer that we are having is the trihexyphenidyl. Okay, trihexyphenidyl. Dr. Mahesh, why are you confused? Why are you confused, Dr. Mahesh? है ना? मैंने in the crash course I have discussed antipsychotics. In fact, I have taken a separate session of 1 hour just on those antipsychotic drugs, and all the question have been summarized. Why are you confused? You can let me know your reason of confusion. एंटीसाइकोटिक्स ड्रग में टिपिकल है, एटिपिकल है, ठीक है. टिपिकल वाले मेनली D2 ब्लॉकर हैं, उसमें मल्टीपल सब क्लासेस है, लाइक फिनोथायाजीन, है ना, देन ब्यूटाइरोफिनोन्स, है ना, लाइक ड्रग्स लाइक हेलोपेरिडोल, ड्रोपेरिडोल, बेनपेरिडोल, दे आर द ब्यूटाइरोफिनोन, है ना. फिनोथायाजीन्स में यू आर हैविंग ड्रग्स लाइक योर क्लोरप्रोमाजीन, थायोरिडाजीन, है ना, ट्राइफ्लूपेराजीन, परफेनाजीन, फ्लूफेनाजीन, दीज आर ऑल, है ना, typical antipsychotics. ठीक है. Do not be confused. You can let me know the problem that is creating confusion. ठीक है. I hope this query is sorted. Because the typical D2 blockade, there will be, right, what you can see, there will be this particular problem, imbalance between the dopamine and acetylcholine. Therefore you should bring the acetylcholine down by centrally acting anticholinergic, right? You call this condition as a secondary Parkinsonism. Okay, a patient was given muscle relaxant that competitively blocks nicotinic receptor. Question को बहुत ध्यान से देखिएगा. Read the question very very carefully, right? It is blocking mainly nicotinic receptors. Yes. Which of the following drug is used for the reversal of muscle relaxation after surgery? Okay. I hope all of you guys, है ना? Definitely, Dr. Mahesh, we can schedule one session, but since this is a PYQ session, we cannot use this session to discuss the antipsychotic, but definitely I can discuss it in the upcoming session that we are having. So B, majority of you are in favor of neostigmine, A and B. Okay. Some of you are telling A as well, that is physostigmine. Now remember, when the drug is blocking a nicotinic receptor, you are having two kinds of nicotinic, right? NM. Now for the muscle relaxation, pre-operatively, you are going to block NM only, right? NM blocker. Now this NM blocker will be your depolarizing muscle relaxant, that is your succinylcholine. This is used mainly for the endotracheal intubation because of the shorter T half-life of around, right, 15 minutes, right? They are used, not 10 to 15 minutes, they are mainly used for the endotracheal intubation. Then you are having your non-depolarizing muscle relaxant. Non-depolarizing muscle relaxant that is mainly going to block the NM, right? They are mainly going to block the NM. Okay. So mainly this NM blocker that we have, we are talking about this one mainly. Okay, non-depolarizing muscle relaxant. Now if you want to, right, reverse this toxicity, then you will be using neostigmine. Now what this neostigmine will do, they are the acetylcholine esterase inhibitor. Because of this particular reason, there will be increased amount of acetylcholine. The level of acetylcholine, boys and girls, will be increased, and this acetylcholine that is increased, usually it is going to act on the nicotinic and also acting on the muscarinic receptor. Because acetylcholine is a neurotransmitter for nicotinic and muscarinic both, you want your action only at the NM receptor. You do not want your action at the muscarinic receptor like M1, M2 and M3. Because acetylcholine at the M1, if they are going to act, they will be increasing the acidity, increasing the risk of peptic ulcer disease. By acting on the M2, they are going to cause bradycardia. By acting on the M3, they will be causing bronchoconstriction, excessive salivation. Right, excessive salivation. So that all this problem can also be, we can overcome all this problem by simply blocking M1, M2 and M3. So along with the neostigmine, what is the one must adding drug that you will be doing will be atropine. You are supposed to add atropine along with the neostigmine as well. Okay? Same goes for the snake bite as well. The only difference is that in the snake bite it will be poisonous dose, but here you are going to give a controlled dose, right? So neostigmine के साथ you will be using atropine. Why not physostigmine, guys? Because physostigmine is one of the tertiary amine. Tertiary amine. You do not want your action in the brain. Anyone that is tertiary amine will be lipid soluble. You want your action only in the peripheries, right? Therefore, what you are going to do is give the neostigmine that happens to be one of the quaternary amine. You will not be using succinylcholine because succinylcholine itself is going to cause muscle relaxation. ठीक है, कार्बाकोल clinically not used, earlier it was used for the glaucoma. बात मेरी समझ में आ गई? So I think this much information is good enough for a question like this. Moving on to the next question. Now there is a patient that was diagnosed with rheumatoid arthritis, right? After 2 years he developed blurred vision. Very very commonly asked question, multiple time repeated question, right? Repeated question. He was found to have corneal opacity, right? So blurred vision, corneal opacity, most likely drug. Come on guys. Come on, please, all of you, provide the answer for this question. The answer has started to come, chloroquine. Excellent. Okay. So the condition that it will cause will be your bullseye maculopathy. Okay, bullseye maculopathy. Remember, boys and girls, this bullseye maculopathy that is caused by this chloroquine that we have, or HCQ, hydroxychloroquine. It is an irreversible condition. So that is one problem that can be seen. Blurring of vision or corneal opacity can be seen with the chloroquine. Remember, okay? Chloroquine के साथ होगा. Correct answer is B. Then in some of my session previously, I have told you multiple drugs causing ocular side effect. Multiple drugs causing ocular side effect. So ocular side effect is caused by what all drugs? Can any one of you tell me what are drugs that you know that is causing ocular side effect? Like for example, I can give you antipsychotic drug, a atypical antipsychotic drug, quetiapine, right? Queen, andhi, causing cataract, andhirani, and causing cataract. Very good. Some of you have mentioned about amiodarone as well. That is causing your corneal microdeposits. Corneal microdeposits. Yes. Ethambutol, that is also causing your optic neuritis. है ना, ऐसे आपको कॉन्सेप्ट होना चाहिए. ऑक्यूलर साइड इफेक्ट कौन कौन सा ड्रग करता है ना. विगाबैथ्रीन दैट वी आर हैविंग कैन ऑल्सो कॉज, राइट, विगाबैथ्रीन that is cause peripheral retinal atrophy. Because of that there is a decrease in the right vision field, decrease in the field of vision, that is your tubular vision. It can cause development of the tubular vision. Why tubular vision? Because of the peripheral retinal atrophy, because of the peripheral retinal atrophy. In the antipsychotic drug you are having thioridazine. This is the only antipsychotic drug, guys, that can cause retinal pigmentation. Only antipsychotic drug that can cause retinal pigmentation, also termed as the browning of visits. Okay, browning of visits. ठीक है, this is how you should know. Multiple drugs are there that is causing ocular side effects. Some of them I have mentioned it here. Quetiapine, amiodarone, ethambutol causing optic neuritis, and therefore it is not given in the pediatric population. Vigabatrin, causing visual field defect. Ivabradine is also causing, right, ivabradine, it also decreases the visual acuity. Ivabradine is one of the bradycardia inducing drug used in the angina, and ivabradine, it can also affect the visual acuity. Steroids can also cause, steroids that we are having, right? So remember, steroids can cause both. Glaucoma can also be caused. Glaucoma will be caused by the topical steroids. It can even cause cataract. It can even cause cataract by systemic steroids. Very easy way to remember in the examination without making any mistake is the mnemonic GTCS. GTCS I have told you a couple of times already, right? Glaucoma will be caused by topical drugs and cataract will be caused by systemic steroids, right? So GTCS that I have told you a couple of times already. Do not forget, glaucoma by the topical, cataract by the systemic. Okay? So a lot of information we have summarized in this particular question, and I hope we can go to the next question. Okay, this particular slide is telling you uses of the chloroquine, that is remembered by the mnemonic prem dil se. Photogenic reaction, rheumatoid arthritis, extraintestinal amoebiasis, malaria, discoid lupus erythematosus, infectious mononucleosis, and in COVID-19 also. Remember, not FDA approved, but off level it has shown good result. Okay? Not FDA approved. The only FDA approved drug for COVID-19 is remdesivir, RNA dependent RNA polymerase inhibitor. Okay? Next question. Very good question. Anti-arrhythmic drug that is contraindicated in the interstitial lung disease. I will take at least 2 to 3 questions more and then we will end because time is running really fast. Let's do a little faster. All of you please respond kariye. Anti-arrhythmic drug that is contraindicated in patient with the ILD, interstitial lung disease. Excellent. Shantan Basu. Other students also jaldi bataiye. In the interstitial lung disease, because amiodarone also causes your pulmonary fibrosis, है ना? They themselves cause pulmonary fibrosis. ठीक है? So amiodarone is the correct answer. The most common side effect, if the examiner is going to ask you, that is your thyroid abnormality. Okay? Thyroid function abnormality. This thyroid function abnormality that is caused by them will be going in either direction. It can cause your hyperthyroidism. It can go in hypothyroidism as well. दोनों में से कोई कर सकता है. ठीक है? So correct answer is amiodarone. Clear? Okay, a patient was on warfarin therapy. The gamma carboxy residue of which factor will not be formed? I mean, this is the easiest question today that I am asking because we have been reading vitamin K, we have been reading about warfarin multiple times. Yes, amiodarone can cause, busulfan can cause, bleomycin can also cause, cyclophosphamide can also cause. All of them. Dr. Sneha Manchanda, yes, they all can cause pulmonary fibrosis. You can add one more drug to your list, bleomycin. Okay? B as given by all of them, yes, exactly. So they are the inhibitor of they inhibit vitamin K dependent clotting factor, that is the 2, 7, 9 and 10. Okay, factor 2 is the last factor to reduce, last factor to be inhibited, that takes around 5 days. 4 to 5 days will be taken by factor 2. Okay. First line treatment of postmenopausal osteoporosis. Let us see how many of you can get this. First line osteoporosis drugs for the first line treatment for postmenopausal osteoporosis is done by estrogen, bisphosphonate, raloxifene, thiazide diuretics. वेरी गुड. तो जितनी जल्दी आप करेंगे उतना ज़्यादा नंबर ऑफ क्वेश्चन हम कर सकते हैं. एक्सेलेंट ऑल ऑफ यू गाइज. नाउ द आंसर इज कमिंग बी एंड डॉक्टर नम्रता इज इन फेवर ऑफ सी. Aditya is also saying C. Everyone is in favor of B. Okay. Now remember guys, whenever they say the drug of choice for any age group in osteoporosis, postmenopausal, right, or any age group, right, the drug of choice for osteoporosis is going to be bisphosphonate, not raloxifene. It is going to be bisphosphonate, happens to be the drug of choice. Clear? You can use other drugs as well, but not the drug of choice, right? Preferred drug, first line drug of choice, bisphosphonate is the one. इतना बस याद कर लीजिए. ठीक है. Raloxifene, one of the selective estrogen receptor modulator that can be used, but the drug of choice is always and always bisphosphonate. What is the mechanism of action of bisphosphonate, guys? Can any one of you can give me what is the mechanism of action of bisphosphonate? Come on, faster. I'll give you a hint. It has to do something with the osteoclastic cell. Time is running really fast. Come on. No, the mechanism of action of bisphosphonate. Dr. China, Vivekananda China. Okay. Inhibit the osteoclastic resorption. Okay, very good. So it inhibits the osteoclast mediated resorption. Okay, osteoclastic resorption को ये inhibit कर देता है. So what will happen? This is the bone and this is the osteoclast that we are having brush border end. Right, these drugs that we are having, they are going to be deposited over the bone, right? They will be deposited over the bone, and once they are taken inside, right, once they are taken inside along with the calcium, they are taken inside, and once they are going inside, they will inhibit the overall reabsorption, right? So this is the osteoclast. So osteoclast mediated resorption will be inhibited along with the bone, right? They will be taken inside and they inhibit the further uptake of the bone, right? So osteoclastic, right, osteoclast mediated resorption, right, inhibits resorption. ठीक है, clear हो गया? Inhibited resorption is the mechanism of action. Second thing that you should know is the side effect. Very commonly asked question, bisphosphonate का side effect. One you should know guys, can cause gastroesophageal reflux disease, or you can say esophageal irritation, है ना, esophageal irritation, right, GERD, esophageal irritation, and osteonecrosis of the mandible, right, osteonecrosis of the mandible. ठीक है, clear? Moving on. Which of the following anti-anginal drug act by late sodium channel blockade? You see, we did lot of question today and we have discussed a lot of information in this particular session. So every day we'll be discussing at 6 p.m. PYQs, and it will help you in revising, retaining multiple new information, right? 4 p.m. at app I will be live, 6 p.m. on Unacademy YouTube channel I will be live. Okay, all these sessions are absolutely free for all of you. Okay, so late sodium current blocker that we are having, right? The name of the drug, come on, all of you. Yes, very good. Ranolazine is said by Sneha. Some of you are saying it is C as well. Anita is saying C. Trimetazidine. Okay, so correct answer that we are having is ranolazine. Although trimetazidine, ranolazine is one of the fatty acid oxidation inhibitor, and the drugs that is acting by inhibiting late sodium channel blockade will be ranolazine. Okay, ivabradine is the funny current blocker. Okay, ivabradine is the funny current blocker. So remember guys, whenever there is ischemia, there is a late sodium current activation, and this ischemia, right, because of this late sodium current influx, more and more sodium will be there intracellularly. And remember, intracellularly sodium is never physiological. Because of this, there will be activation of NCX, sodium calcium exchanger, and they are going to cause more and more calcium overload. You can totally understand, no, inside the myocyte, if the calcium overload will be there will be increased risk of arrhythmia, and also there will be diastolic wall arrest, right, diastolic wall stress. So during diastole, the myocardial wall that we are having, during diastole, what is happening? The myocardium should receive the oxygen. But whenever there is a diastolic stress, what will happen? The myocardium will not receive the oxygen. So there is a decreased oxygen supply, right? Increase in the oxygen consumption and decrease in the oxygen supply, and that will further add on to the ischemia. Remember? So the current more preferred mechanism of action that we are having currently for ranolazine is simply block this late sodium current, right? Late sodium current. Yes, Dr. China, it is used in a chronic injury. Yes. Once you block this late sodium current, right, then what will happen? This whole process of the NCX activation will be stopped. This whole calcium overload, arrhythmia or diastolic wall stress, everything will be stopped. Getting a point? So I hope all of you guys have enjoyed this session today, and tomorrow I'll be live again at 4 p.m. and 6 p.m. to discuss more question about pharmacology PYQs, right? Okay, एक question और ले लेते हैं, last question. एक और question है, a patient presented with biliary pain, the intern posted gave an injection which further increased the pain. Which of the following drug could have been caused this increase in the pain? Last question. This is the last question. अरे नहीं डॉक्टर महेश, थैंक यू वेरी मच फॉर द कॉम्प्लीमेंट, बट नहीं, वी आर स्टिल इन द लर्निंग फेज एंड वी ऑल आर गोइंग टू बी लाइफ टाइम स्टूडेंट्स, है ना? चलो, वेरी गुड. सो करेक्ट आंसर दैट वी आर हैविंग इज यस. Which agent can cause? So remember, biliary pain or any spasmodic pain can further be increased by morphine. Right? It can aggravate. Therefore, it is contraindicated in colicky pain. Any colicky pain, right? Or any biliary, right? Biliary or renal colic. Any type of any such colicky pain that we are having, है ना? They will be contraindicated because they smooth muscle का contraction कराते हैं ना ये, and they can also increase the tone of the sphincter. They cause smooth muscle contraction. They increase the tone of the sphincter. You can totally understand the pain will be aggravated. ठीक है? So dicyclomine definitely can be used. Dicyclomine is a smooth muscle relaxant that can be used. ठीक है? So that will be everything that I wanted to discuss with all of you guys. Every day at 4 p.m. remember, and at 6 p.m. at YouTube, and at the Unacademy app I'll be live discussing the important MCQs. At the app currently we are discussing the antimicrobial. So tomorrow at 4 p.m. I'll be discussing antimicrobial. Thank you very much guys. Thank you very much for your presence and attendance. Yes, bilkul, it will be causing sphincteric spasm as I told you, Dr. Mahesh. Thank you very much, Dr. Namrata and Shantan Basu, right? And thank you all of you. I'll see you guys in the upcoming session, right? Have a good night to all of you. And for all of you, those who are in the second year, for the second year students, I will be coming live at 9 p.m. Okay, so at 9 p.m. Focus Prof will be there. At 9 p.m. today also I'll be coming live. Focus Prof. So Prof exams of all the top medical colleges of this country like AIMS, MAMC, we will be discussing all their questions. Tonight's topic in the Prof exam once again will be antimicrobial. So I'm discussing a lot about antimicrobial because most of the students are usually very much afraid and they tend to leave this topic. But I want to make you fall in love with every topic of pharmacology. That is the main goal, to make the pharmacology as easy as possible and make you one of your favorite subject. That is the main goal that we are working towards. Okay, so thank you very much guys. Have a good day. Have a good night to all of you.